Thank you, Dr. Ann, for giving me this opportunity. So, watering is one of the most common complaints that a patient comes with in our OPD. So, how do we approach a case of watering? Watering, it is not just all cases of watering is epiphora, or not just all cases of watering is due to nasolacrimal duct obstruction. How is it different from epiphora? When you call, so epiphora, it's a condition when there is excessive watering and it overflows over the cheeks. So first and the foremost, what you have to do is to rule out any causes of reflex hyperlacrimation. So reflex hyperlacrimation, it could be due to ocular surface irritation, allergy, and often you can see that it is always associated with redness. So in your history, it should be very meticulous. You have to ask the history of any topical drugs, especially anti-glaucoma medications, which are notorious in causing punctal stenosis and canalicular obstructions. Always ask the history of any prior surgery, especially any ENT nasal surgery, so the sinal surgeries, or even the patient might have done DCT prior and had come with watering, complaints of watering. Always ask any history of any facial trauma and ask the history of any facial palsy, because facial palsy can cause watering due to many causes, which we will be dealing later. So coming to the examination, and prior it will be divided. Watering can be divided into functional causes, or the non-obstructive causes, and the obstructive causes. So on examination, always have a look at the lids, because this could be a cause of watering. Here you can see it is an entropion, and this is a case of trichiasis, and this often there will be a lid mass which can even rub the cornea and cause watering. This is a case of the lady has got an ectropion as well as lag of thalamus, and you can see that the fluorescein dye test is positive. So this is a case of facial nerve palsy. And facial nerve palsy, the patient can even come with history suggestive of gestatory lacrimation. Now moving to the obstructive causes. So this everyone knows, this is a normal outflow system. It starts with the puncta, canaliculi, and the sac, and the nasolacrimal duct. So any pathology anywhere in this causes watering. So we start with the punctal disorders. This is a child who came with watering, and you can see that the punctum, there is agenesis of the puncta. This can be associated with canalicular agenesis also, or even NLDO. And this is a very even more commoner condition, which is the punctal stenosis, and most of the time it is post-inflammatory. And there can be punctal masses, punctal nevi occluding the puncta, and accessory puncta, or the last case, it's a punctal ectropion, which is caused by the, you can see it is caused by the caruncular hypertrophy. This is a more common condition, which often the postgraduates misdiagnose as a case of chronic dacrocystitis. Here, the swelling, it's a peripunctal swelling, and the puncta is severely inflamed, and you can see the pouting puncta. It's a case of canaliculitis. Excuse me. And always look at if there is any redundant conjunctiva which is blocking the puncta. This is a case of conjunctivochalasis. Now, this was a young male who came to OPD with watering, and he has a prominent nasal bridge. So this is Centurion syndrome. Here, the watering is due to the fact that there is anterior insertion of the medial part of the anterior limb of the medial candle tendon, and what happens is that the puncta is drawn away from the tear lake. So once you are done with the puncta, if it is normal, it could be due to the canaliculus or the nasolacrimal duct. So the normal ones, so it's time to syringe and probe if everything else is normal. So on syringing, normally it reaches, this is the pathway, and reaches the inferior meatus. So if there is a canalicular obstruction, syringing it regurgitates to the same puncture, and on probing you get a soft stop. If it is a distal one, that is NLDO obstruction, syringing finding, there will be regurgitation of the fluid through the opposite puncture, and you will get a hard stop. So the cases of chronic, NLDO obstruction can be associated with a fluctuant swelling. You can see it's a mucocele, and often on pressure over the lacrimal sac, there will be regurgitation of the mucus, and sometimes there can be even lacrimal sac fistula. So endoscopic evaluation can be done, and this can exclude the intranasal pathology and also exclude intranasal variations adversely affecting the endonasal surgery. Surgery which includes the deviated nasal septa and the concha bullosa. This is only in cases where when we approach it endoscopically. So imaging is indicated in only cases, in conditions of facial trauma, nasal surgeries, and in cases where there is bloody tears or nasal obstruction and epistaxis, such as when you suspect sac malignancies or the vaginous granulomatosis and such conditions. So a quick slide on the watering in children. Majority of the cases, it's due to the nasolacrimal duct obstruction, and it's most commonly due to any membranous duct obstruction. Other variants such as duct atresia or the bony obstruction can also contribute. Sometimes it could be due to the agenesis of the puncta canaliculus or supernumerary puncta, or the duplication of the canaliculus, or even the lacrimal sac fistula. So often in the OPD, it's very difficult to examine the child, and this is the very quick and the easiest test to determine if there is any significant obstruction. That is a fluorescent dye disappearance test. All of us know we are instilling the fluorescent in the cul-de-sac, and we are observing the child after 5 minutes and looking at if it is more than 2 millimeters, it's a case of positive. And often in such cases we'll have to do under anesthesia, examination under anesthesia, or syringing and probing. So to conclude, it is very important that you evaluate the case thoroughly and to get an accurate diagnosis. Otherwise, we may have to cry upon a patient with watering. Thank you.
Thank you, Dr. Indu, for the elaborate coverage of